Hi, my name is Dr. Tim O'Connor, and I'm the Director of Minimally Invasive and Robotic Spine Surgery here at the Marcus Neuroscience Institute. I'm a fellowship-trained neurosurgeon specializing in minimally invasive spine surgery, and I'm also faculty within the Department of Surgery at Florida Atlantic University. I see patients at Boca Raton Regional Hospital and Bethesda Hospital East and West, all part of Baptist Health. I actually grew up around South Florida, and after training at the University of Florida and then Buffalo, New York, where I also did my fellowship, I couldn't wait to come back home to help people around the town I grew up in. So robotic technologies evolved over several generations to advance minimally invasive techniques and integrate computer guidance in the operating room. Although traditional techniques for spine surgery are still widespread, newer technology has increased the reliability of accurately planning surgery with smaller incisions and subsequent decreased length of hospital stays. Robotic surgical systems assist with aligning the ideal working trajectory for each patient, and they improve the ergonomics throughout the surgery using the advanced tools within the robotic platform. There's less blood loss than traditional surgery because I can use the advanced planning system for targeted guidance on exactly where I need to go with a smaller incision. And so this also results in less pain for the patient and a faster recovery after surgery. So there are several robotic platforms that have been developed, and the Mazor robot's an advanced surgical platform that combines advanced planning software, computer guidance, as well as a robotic effector arm to assist me during surgery. Using the surgical software integrated into the system, I can align the ideal trajectory for each patient's unique anatomy using their own imaging. I can essentially plan the entire surgery before the patient even steps into the operating room and see their anatomy with 3D virtual imaging. Robotic-assisted techniques can also help significantly decrease radiation use to both the patient and the treatment team. The patient's preoperative imaging can be merged with robotic planning software without any additional CT scans. The computer navigation systems that are now integrated into the robot allow improved visualization of the patient's anatomy with real-time guidance without the associated radiation. In addition, the significant increase in accuracy while using robotic technology helps reduce concurrent fluoroscopy use to reposition a screw that may not be placed as accurately without this technology. Studies have reported nearly a 74% reduction in radiation exposure when robotic guidance platforms are used compared to typical fluoroscopic guided techniques. Several of the studies I've published have answered the question of how this technology benefits patients. Using a minimally invasive technique with a robotic system significantly improves the recovery and decreases the length of hospital stays. On average, patients stay around 1.5 days before going home after surgery, and the hospital stays can be over double this with more traditional techniques. After conservative treatment options have really been exhausted and the patient is continuing to have symptoms, any patient requiring spine surgery can benefit from a more minimally invasive approach using this technology. So I published multiple papers on robotic technologies, and I presented at the Congress of Neurological Surgeons, among many others. And here's a case study using robotic technology that you may find interesting. It's the story of a 60-year-old woman with a history of prior left-sided fusion from L3 to L5. Her symptoms resolved postoperatively and she was doing very well. The following year, the patient returned to clinic with progressive symptoms from the level below, with bilateral S1 radiculopathy and progressive mechanical back pain. She completed 6 months of physical therapy without relief, and we then discussed surgical options. The preoperative lumbar MRI demonstrated an L5 S1 disc bulge with disc collapse and modic changes at L5 and S1, with loss of segmental lordosis secondary to adjacent segment disease. After discussing the various surgical options, we proceeded with anterior lumbar interbody placement with restoration of segmental lordosis and indirect foraminal decompression. This picture shows her imaging after the anterior lumbar interbody fusion. For the second stage of the operation, I then used the robotic platform to perform a minimally invasive surgery. These images show her x-rays after using the robotic platform to accurately place these screws in a minimally invasive fashion. Postoperative CT demonstrated excellent placement of all instrumentation. The patient did extremely well after surgery. She was able to go home after several days and was delighted to get back to her normal everyday activities. If this is something you think your patients can benefit from, please reach out anytime and I'd be happy to help.